some fat-soluble vitamins, stuff like vitamin K that the E. coli are producing within the large intestine. And that is reflected in the epithelia and mucosa that we see. But looking at the structure, the ileum is going to come into and enter into the small intestine. It's called the ileocecal valve. However, the ileocecal sphincter, but it's more of a slit than a well-developed circular smooth muscle. So it's also known as the ileocecal valve or the ileocecal sphincter. And you can visualize that on this plasticized region of the cecum. And it's all the fecal matter has been flushed out. Okay, so it's clean. I don't think so, but I'm not positive. It's also dilated in the process of plasticizing it. But here's the ileum, so you can see the circular folds, the plicae circularis. And when you look in here, you can see the ileocecal valve. And then you can also see the appendix. Many times the appendix is tucked under the back. And this one's about a little over 4 inches long. So this is identified as the complete name is vermiform, but you are welcome to just call it appendix. And remember the ileum is intraperitoneal. The appendix also has a mesentery, so it is considered to be intraperitoneal. And this would be the mesoappendix. That's not on your lab list, but the mesentery of the appendix. And so I'm showing it hanging down there, but like I said, many times it's tucked up and behind.
You said we don't got another video for this?
No. So this is the cecum, which is the blind pouch-like structure of the beginning of the colon. And this would be the ileocecal valve or sphincter. And then we see the intestine itself is about 4 feet long, okay, between almost 4 and 4.5. And so it forms this upside down U shape. On the right side, it moves up to the liver. And the liver is going to be affecting its height, just like the right kidney is lower than the left kidney. So when this bends and we see the hepatic flexure, it's going to be a little bit lower than our splenic flexure. So flexure is the point of bend. It's also on the right side. So if you can't remember which side the liver is on, another term is the right colic flexure. And then we continue to see our transverse colon. And we have our left, our splenic or left colic. And so this would be the ascending colon, transverse colon, and ascending colon is going to be retroperitoneal. Transverse colon is intraperitoneal. What you're seeing here is the transverse mesocolon. And that's suspended from the posterior abdominal wall. So I don't know if you remember when we did the sagittal view, and we had the stomach, and we had the colon, we had the greater omentum coming up and attaching to the transverse colon, and then going around and then attaching to the posterior abdominal wall, and that was our transverse mesocolon. Okay, so it's just a band of connective tissue that suspends the transverse colon from the posterior abdominal wall. So this would be transverse mesocolon. And then we come down the left side.
Once we say transverse, intro or retro?
Pardon?
Is that intraperitoneal or retroperitoneal?
Oh, sorry, yeah, because this is the mesentery, that would be this intraperitoneal.
Thank you.
And then we have the descending colon, which is retroperitoneal. Our sigmoid colon, because of this double S-shaped curve, and this also has a mesentery. We can't see it in lab because the small intestine covers over it, but that would make the sigmoid colon intraperitoneal. Alright, then after the last final bend of our sigmoid colon, then we have the rectum and anal canal. Rectum means straight, as you remember from vasa recta. So this straight portion is the rectum. Okay? Now we use our plicae circularis, and we'll go back and do the GPAT, look at the mucosa and submucosa components, but just a couple of more structures to label. The outer longitudinal layer of the muscularis externa is restricted to 3 bands rather than completely forming a cover entirely around the colon. It's limited to 3 bands, and you can see those on this plasticized section. And those are the isolated bands of longitudinal muscle. And they have a slight contraction that gives us these pouches. And there are 3 bands, so they're kind of evenly spaced apart. So I'll draw one in here, and the other 2 would be posterior. And these are identified as the tinea coli. Three bands of outer longitudinal muscle.
On the descending, why are they broken up? Or they're broken up completely?
So this would be, because it's going around, you're not going to see all of it. It's just my artistic license. All right, so that's the anatomical structures. The models that we have are limited to the models from the torso. So this is probably the largest one. So it's situated like this, all right? And you can see that this would be then the transverse mesocolon, okay? And the sigmoid mesocolon is not quite as clear as a separate mesentery, but these 2 components, the ascending and descending colons, are retroperitoneal, and then rectum and anal canal.
It kind of looks backwards though, because it looks like the sigmoid is actually further back than the descending.
Further back?
Yeah.
You mean more posterior?
Yeah.
This is kind of this would be the parietal peritoneum. So it's kind of going over the edge of the iliac, the pelvic bone here. Maybe that's why. All right, so now let's look at the mucosa, submucosa, muscularis externa pattern. You guys done with the diagram? Quite. Pardon?
Everyone's got a colonoscopy.
There you go. All right. So we still have, until we get to the anal canal, we still have the same epithelial tissue that we had when we started with the stomach. So we look at our mucosa. We're going to continue to see simple columnar epithelium. Remember when I drew the schematic of the three regions, the small intestine, stomach, and large intestine? We had the villi and intestinal glands in the small intestine, gastric pits and gastric glands. Now that we get to the large intestine, the mucosa is just intestinal glands without any extra features. Okay? And our muscularis mucosa here. So our epithelium is still a simple columnar epithelium. The only modification is about 25% of the cells are goblet cells. There are so many that it actually looks like a higher number, like 50% or more. So here's a view. You can see the regular long length of the intestinal glands with that additional frills. All these white oval structures would be the goblet cells, and they look much more than 25%. Looks like almost all of them are goblet cells, okay, in the muscularis mucosa. And so it's a distinctive appearance. Remember, the stomach doesn't have any goblet cells. So we'll look at the transition from the non-cornified stratified of the esophagus to the stomach. We see the white mucus cells are just at the top. But when we have a transition between the non-cornified of the anal canal to the rectum, which has the same epithelium as the colon, we have the entire length looking white because of the goblet cells. All right, so we have still our lamina propria, loose irregular connective tissue, and our standard muscularis mucosae. So this would be the key difference right here between other components, the lack of our villi. The submucosa is standard. In other words, distant irregular connective tissue, nothing different. Our muscularis externa is where we see the next major modification. So we have an inner circular, and our outer longitudinal becomes the Taenia coli. And then our serosa is standard.
I'm sorry, what is standard?
Standard is back to the template. So it's just the serous membrane of the loose irregular connective tissue and simple squamous. So the very beginning, when I went through the mucosa, submucosa, so it's just nothing unusual.
GPAP or something like that.
Yeah, exactly.
So this is the first thing on the group.
Yeah. So here's a posterior view of the ascending colon, and you can see one of the Taenia coli, and it leads straight to the appendix, so that can be helpful in surgery sometimes. If you can't find the appendix, it's tucked up under or on a cadaver. The appendix is thought to what's a lymphatic organ. It has a narrow lumen, and the wall is filled with lymphatic follicles, very similar to the ileum, except in the histology section it's circular. And it was just kind of, well, if we're in there doing surgery, we're going to go ahead and take it out, because if it ruptures, you could get peritonitis and die from sepsis. But about 2 years ago, British Journal came out with a theory, nothing proven, that the reason we still have an appendix is just in case we happen to get Montezuma's revenge and extensive diarrhea, we can repopulate our normal bacteria with bacteria in the appendix. Well, okay, but babies are born without bacteria in their large intestine, and they just develop it, and it grows up, colonizes. I'm sure that can happen to us again. So it's a theory, but I'm not sure that it actually proves that still that we have a need for it. All right, so here you can see part of the blood supply, just as a review. This would be the transverse mesocolon again, but here's the inferior mesenteric. And remember, its blood supply is going to go up to the splenic flexure as the left colic branch, sigmoid, and to the top of the rectum. Whereas the ascending colon, it's getting its same blood supply as the small intestine. Where the two meet and actually overlap to some degree is in the area of the left colic or splenic flexure. We see the same transition in the innervation, the parasympathetic innervation to the colon. So vagus, which has been innervating esophagus and stomach and small intestine for parasympathetic motility and secretion, stops at the same area where the superior mesenteric artery stops its blood supply. Anybody know what are the parasympathetic fibers that come from the distal inferior spinal cord? Remember from reproductive? Parasympathetic, no. Pudendals are voluntary motor. Pelvic splanchnic. Okay, so parasympathetic coming from the sacral spinal cord are going to be supplying the pelvic splanchnic nerves, are going to be supplying the descending colon. Now, before we move on to the rectum, I wanted to illustrate all these goblet cells and what happens when we don't have them, because as we move fecal matter through the large intestine, more and more water is absorbed, and the fecal matter becomes drier. It's one of the, pardon? Yes, it's one of the reasons for having a lot of soluble and insoluble fiber in your diet, is because that draws water out and helps to maintain a softness to the fecal matter. About the early 80s, mid to late 80s, 86, 87, I had a client, a patient. I was working weekends at the hospital at Sutter, but a friend of mine who was a county home health nurse said that she had a client who was living in Davis and needed somebody to come over every week or two and give him intimates. He was almost 80. He was about 78. And he had never been able to go have a normal bowel movement since he was 5 years old. He grew up down near Bakersfield and had eaten some lima beans sprayed with pesticide. I don't know how his esophagus and small intestines recovered, but there was such an extensive degree of chemical burn that the mucosa of his large intestine was gone. So he didn't have those lubricating, mucus-secreting goblet cells. Plus, he had adhesions in scar tissue. So material would get in there and then just wouldn't be able to get through it and would just back up and constipation. So he had to have high colonic. By high colonic, I'm talking about up in the transverse colon. Now, most of us have a bowel movement every 1 to 3 days. More often, the more food you eat, kind of a thing, or exercise, or a diet affected. He was still a working guy. He still worked full time. He had 2 jobs, one down in Southern California and one up here. He would be so busy that sometimes it'd be 2 or 3 weeks before I'd get a call. And you can imagine what you would feel like if you didn't go to the bathroom for that long. You started reabsorbing the toxic waste of the bacteria and gases and stuff. So the first evening I went over there, a typical fleet enema that you can buy in the drugstore, or you might get the night before surgery or something, is about 1.5 cups to 2 cups of water. And he had a contraption that looked like a glass blender without a bottom, that hung from a IV pole, held about 2 to 2.5 quarts.